Okay, great. Well, thank you all for being back here for the continuation of our program. We're now going to move to a very important topic, which is improvements in the public and private payer system. And I think that all of us recognize that as we move forward with attempting to implement the various recommendations, policies, and procedures that have been put forth in this and so many other venues, that ultimately there's a linkage to how payment takes place. So today we have two wonderful individuals taking different sides of the equation, and they are surrounded by myself and Judith Perez. Judith is now leading the Pew effort that is looking at end-of-life care, but importantly, she was a very valued member of the committee that led to the Dying in America report, so I want to thank her for that, and she's going to co-moderate this session with me. And I want to introduce our two panelists. They're each going to speak first, then we'll engage in some dialogue, and as we did earlier, some questions and answers. So I think that from my very biased point of view, one of the most important perspectives to deal with the life continuum, policy and health, is that of the pediatrician. So I'm very pleased that Patrick Conway fills that bill. So he began his life in pediatrics and moved to dealing with much more ethereal issues. I have to say, when I started in pediatrics, I don't know if it was true for you, it was to avoid being involved in the elderly, and here you are now, being the Deputy Administrator for Innovation and Quality, Chief Medical Officer for the Centers of Medicare and Medicaid. I'm one of your clientele. So we're so pleased that you are here with us today. Your role is really, really very, very important, and we'll be very interested to hear your perspective. And just to shape it a little bit, I think one of the things we'd love to hear is when you're going to be implementing some of the recommendations of our committee. And then to my immediate left is an old colleague, Hal Paz, who I knew well as a dean, a co-dean. He was the dean at Penn State. He had the benefit of going to the same medical school I did, where we learned about the biopsychosocial model of healthcare. He was there ahead of me. No, I'm just kidding. But he left there just a couple of years ago to join Aetna, where he serves as Vice President and Chief Medical Officer, and is really involved in a lot of the important policy issues that speak to some of the issues that we are going to deal with today. And Aetna is one of the insurance companies that's really been a pace setter in setting new policies and initiatives. So I think we'll be very interested to hear his perspective as well. Why don't we start with you, Patrick, if that's okay?
Sure, that'd be great. And so I'm actually going to start with a couple patient stories. One is actually, and I think the reason I start with these, I think it'll frame the policy discussion. So one, as a new resident at Boston Children's Hospital, in my pediatric ICU month, in those 30 days, we actually had 11 children pass away. One of the children was a child named Tommy. As a very new resident, his family decided that they wanted to engage me in the conversation around his care at the end of life. And during the course of that early morning hours to when Tommy passed away that day, was able to help them through that time, and I think also was an educational experience for me that I had not been taught in a holistic way how to deal with these issues. I actually asked them afterwards, why did they choose me? Of all the people to bring this up with, I'm the most junior person on the team. There's senior attendings and others that, had practiced in the ICU for a much longer period of time. And what they said that has stuck with me is that because we had built a bond, they felt comfortable raising those issues. And I think there's a cultural, and this isn't about me as a person, I think it's about the relationship building. Secondly, my own father, and many of you have had this experience, was a Medicare beneficiary and helped him navigate the choice in what we really felt was a false choice at the time, and it's a statutory construct of hospice care, curative care. He had cancer for over a decade, and towards the end of the life, helped him navigate those choices, including, at one point having to fly 1,000 miles to interact with his clinicians and convince them that he did in fact want to go home and die at home, and he wanted to be discharged from the hospital. And we actually have a healthcare oriented family, so if we had those kind of struggles, imagine what happens across America every day. And then lastly, and she's watching on video conference, one of our experts within CMS, who's unfortunately not able to be here today, is with her father, actually at the end of life, and is one of our experts. So, I think the key point here when we frame these issues is it really goes back to these patient stories. And the whole point is to honor wishes of people and families and caregivers, as you all know well. I'll call out 4 areas where we're doing work. One is in quality measures. Just to call out a few examples, we've implemented the hospice quality reporting program with a hospice inpatient data set, a standardized data set for hospice care. I think very importantly, we implemented the hospice CAP survey, which surveys patients and families around their experience in hospice at the end of life. And care planning is included in things like the welcome to Medicare visit. I know I'll be asked about codes, et cetera. I'll pre-warn you that in rulemaking I can't say very much, but you're welcome to ask me.
Okay, I will.
So we'll get
I'll
to that.
ask you right now.
I just lost part of my time. Do you want me to answer that now?
Yeah.
Yeah, okay. So obviously through our, and I heard this came up earlier in the day, through our process, the American Medical Association and physician and clinician specialty societies put forth a code for advanced care planning. We put that in the proposed rule last year to get comments on that code, which is very much a standard process. And in this year's rulemaking, we'll be considering whether to propose that code and whether there would be a payment for that code. Because it's rulemaking, anybody who's been in federal government, we are not allowed to say what we would or wouldn't do in rulemaking. So I know that's not as direct an answer as you would like, but to get that out of the way.
We'll come back to that.
I'm sure we will. This is good. The second area I'll call out is quality improvement. So we are very focused through our quality improvement organizations and our other quality improvement funding on beneficiary and patient-centered care, engagement in care choices and care planning. So it's a major investment of our work at CMS. Third, in innovation, I want to call out some direct programs and some indirect. First, Healthcare Innovation Awards. We have palliative care and hospice oriented models in California, Pennsylvania, Alabama, North Carolina, Maryland, just to name a few, really testing both palliative care, hospice care, and the whole spectrum of what I'd say care choices in a number of arenas. Which actually leads me to one of the models. I've been Chief Medical Officer at CMS for about 4 years. I've been running the Innovation Center for 2. We started on a model called Care Choices fairly soon after I began. It's essentially a model that allows hospice and palliative care services to be delivered at the same time as curative care services. As you all know, and we may speak to this, good evidence from the private sector on improving quality and experience and decreasing resource use. We got a huge number of applications. Actually, the reason we haven't announced the applications yet is we're going through our process to figure out how to handle the very large number of applications. But excited about that model starting and a really exciting time for Medicare. And as you know, in the Innovation Center, if the model's successful, we have the ability to scale or expand that model. So very excited about that model. And then I think we also have a number of payment models from the Innovation Center that, although they may not directly be dealing with palliative and end-of-life care issues, I think indirectly they help. So things like accountable care organizations and comprehensive primary care. I can tell you when you talk to those clinicians and teams in these models, they talk about the spectrum of care and care at the end of life and how to empower patients and families and caregivers with choices. And so, I will sort of end where I started. I think, The goal is to, as you all know well, to honor the wishes and preferences of patients, caregivers, and family members, to really make people as physically and emotionally comfortable as possible with minimal disruption to normal activities while remaining primarily at home. And I think together, as a care team, if we involve patients, families, caregivers, social workers, clinicians, psychologists, care managers, the whole spectrum, nurses, of people that help manage and engage families and caregivers at the end of life, I think we'll have a much better health system, and one that is person-centered and delivers on what all of us would want at the end of life, which is compassionate care that meets our needs.
Thank you. Okay.
Thank you very much, Phil. It's a bit of an irony for me that early in my career, when I had started out in academic medicine, one of my first responsibilities was running a medical intensive care unit at an academic health center. And at the time, and this was in the late 80s, we had care for many patients that were receiving allogeneic bone marrow transplants. And we did a study where we demonstrated that the survival rate for these individuals was roughly around 4%. Similar study was done in Seattle, which came up with almost the same exact number. So we did an intervention where we tried to educate family caregivers about those outcomes and wanted to have a discussion about what were the alternatives. But unfortunately, there really weren't, going back now well over 20 years ago, a lot of alternatives in many cases. So in fact, these individuals that had survived their cancer, their transplant, were in the ICU, had the longest length of stay in the ICU setting, had all types of care provided to them, were on ventilators and dialysis, and I think you can really get an idea of what that was like, and yet the number didn't change. Neither did our intervention per se, because I don't really think we had the alternatives that we have today. And the framework of the report by the Institute of Medicine, I really believe, is an outstanding work of comprehensive recommendations that are actionable by payers and providers about what we can do today on the basis of many, many years of experience. And we've heard this from many of the speakers. It's really about what the community can do together. It's about what providers can do with caregivers and with other parts of society to address the issues of end-of-life care. We at Aetna are passionate about this goal, and I'm just delighted to hear so many individuals reference the work that many individuals at Aetna have been doing over the past several years, about a decade now, to look at how we can take positive action with this regard. We've learned that through our work that new approaches to care can in fact make a difference, a tremendous difference in achieving and addressing the triple aim in terms of improving the care experience, outcomes, while also reducing cost. And specifically, we've seen that comprehensive care, particularly for end-of-life care, can make very important differences in engagement, patient satisfaction and comfort, and very importantly, providing the right care at the right time. So, as a result of our own experiences at Aetna, we strongly support the report's first set of recommendations, which is that public and private payers and care delivery organizations should and must provide comprehensive care. So first, let's just talk for a moment about care coordination and advanced illness. And undoubtedly, the care we provide to patients should achieve three things. One, we have to adequately manage pain and symptoms. We have to make sure that the individuals and their families are informed about the care options that exist before them. And we have to make sure that they receive emotional support and timely referral for palliative care and hospice. We think that's enormously important. We think that programs that provide expert assistance to patients with advanced illness can increase awareness of these care options, thereby aligning patient choice more closely with the desired types of health services. And I think it's well recognized that advanced illness drives a considerable amount of the medical care resource consumption. We talked about that indirectly this morning, particularly acute hospitalization. And given my own career background, I certainly can understand that. And I think as many of you know, and I'm sure The gentleman on my left, Patrick, knows that 25 to 30% of Medicare costs are incurred in the last year of life. And more than 80% of those costs are in the final 2 months, and that often they're associated with acute and intensive inpatient care that often, unfortunately, still provides little clinical or psychosocial value to our patients. So I want to take a minute and just look at Aetna's Medicare membership and give you a sense of some of the work that's gone on. Our enrollees in Medicare through Aetna have about a 4.5% average annual mortality rate. And our compassionate care program is designed for Medicare Advantage and commercial members with advanced illness who elect to participate in the program, and they're given that choice. The way we operate the program is we have trained and experienced Aetna nurse case managers who receive special training and mentoring in advanced illness and palliative care services. And they are specifically charged with helping family members and patients address concerns that they have to deal with in terms of end-of-life issues. These case managers provide patients and their families with psychosocial support specifically, as well as expert counseling in how to manage and cope with their illness and how to facilitate pain and symptom relief. And the nurse case managers who support our Medicare members are exceptionally skillful given the long experience they've had in the program. We've seen some very, very important results in how our members engage hospice care. Once a member has been made informed about the program, we find that they have an opportunity to participate in hospice, and it's a decision that they get to choose. Each year, we engage nearly 3,000 Aetna Medicare members in our compassionate care program. And for the latest year that we have data, which is 2012, the hospice election rate for this group was 82%. And this is certainly considerably higher than for unmanaged populations. But also in our commercial business, we see a similar trend. These are the non-Medicare portion of the population. The hospice election rate there is also 83%, slightly higher. And we believe that this is in part can be attributed to the fact that we've eliminated the requirement for commercial members to give up curative treatment in order to be eligible for hospice benefits. And we think this is enormously important. In addition to that, we've taken a more liberal approach to defining hospice eligibility so that members may receive access to hospice care earlier. Our commercial insured members with a terminal diagnosis of 12 months are eligible for hospice care as opposed to the typical 6-month standard. And notably, we have not seen evidence of increased cost as a result of this. The focus isn't on the cost, the focus is on offering them these services which we think are tremendously important to the comprehensive care they deserve to receive. We've also seen impressive results in terms of member satisfaction. And by developing a trust-based and meaningful set of connections, this care manager relationship with our nurse managers contributes to high levels of family satisfaction rates and actually ranks above the 90th percentile in our surveys. During the nearly 10 years, actually slightly over 10 years that this program has been in effect, we've had no member complaints. Similarly, the results in acute and emergency care utilization are notable, and we've published in the peer-reviewed literature the results of our Medicare Advantage program, and we've demonstrated an 82% reduction in acute days, an 86% reduction in ICU days, and a 78% reduction in emergency room use. And perhaps not unexpectedly, improvement in quality intersects with cost. Savings realized from members electing supportive and palliative care is approximately $12,900 per Medicare member engaged. Of course, this depends on a number of factors, including the length of time that the member is in the program. So there are two conclusions that I would draw from this program. First, that care coordination does improve how the system provides appropriate health services while in fact lowering costs. And second, it's the collaboration and the care coordination that's critically important. By working together, Medicare providers and health plans can in fact build effective infrastructure for delivering effective care management, training, and delivering support as well as evaluating the results. And I think this evaluation loop becomes increasingly important over time. And the collaboration between the different providers and the caregivers becomes holistic and more important than any one piece alone. We think this is enormously important, and as a result, the nation's dollars that support care management within Medicare could have the highest quality and impact with these sorts of programs. So, we strongly endorse care coordinated at the end of life, and we believe that standards supported by evidence must be developed to ensure that we have positively measured outcomes. And we recommend that there are the following standards: a description of qualifications for providing care management for those providing care management, the nature of care management engagement, including time engaged and specific issues to be addressed, for example, informed decision support, psychosocial support, and facilitated pain relief. Third, we think that there should be a requirement that impact be monitored, such as hospice election rate, length of stay in hospice, palliative care consultation and support made available to patients, and of course the fraction of deaths that occur in acute care facilities. And finally, we think there must be measures of patient, family, and caregiver satisfaction as well, so that we can do comprehensive work to understand the impact of these various initiatives. Without a doubt, improving the quality of care for those with advanced illness represents a tremendous opportunity for our country's healthcare system, particularly for Medicare and for individuals, for patients, for families, and caregivers. And I think that when the discussions of choice do not begin until very late in the course of the illness, as we've discussed before, the patient doesn't realize the value of palliative care or hospice, and appropriate support, unfortunately, is often not available. This results in inappropriate and costly care and does not represent patient-informed choice. There is without a doubt the capabilities within our healthcare systems to do better, and we feel strongly that we must. We're delighted to be participating in this program today, and we look forward to the continuation of outstanding discussion. Thank you very much.
Question?
Yeah. Hi. So as we're all here, we're here really at the 50th anniversary of Medicare and Medicaid. And what we know is that we built a system 50 years ago that was what we needed 50 years ago. But now we have a Medicare population. A lot of us have talked about the cost at the end of life. But over 80% of the people who die each year are actually Medicare beneficiaries. So we have this great grand experiment going on now in Medicare, and yet it seems that some of the new models are not really addressing all the elements that we would consider to be good palliative care. And some of the metrics that we do have are not being applied to some of these new models. So I'm just interested in what some of your thinking is on that, Patrick.
Yeah, so a couple thoughts. So one, in the broad models, we are working with providers and think palliative care and hospice-related care is a critical component. In our accountable care organizations and our comprehensive primary care, it's been one of their major foci in terms of care coordination and patient-centered care. I'm a quality improvement person, so I always think we could do better. I always think we could do more. I think, that is a focus that I want our team to have, and we want providers and people across the country to have. On the quality measures, I do, and a number of folks in the audience, I've spoken with this before, when I was in a delivery system, we could get much closer to truly measuring goals of care, and then how well are we meeting those goals of care. We don't have a national measurement system that reliably has a quality measurement framework that assesses goals of care, and then literally how reliably are we meeting those goals of care. I think that should be our ultimate goal. There's a lot of steps to get there, everything from data elements to electronic health records to things I won't go into unless you want me to. Is that joke? And you've got expertise in this room and across the country, I think, to help get us there. And then, I think the Healthcare Innovation Awards and Care Choices model that I mentioned, I think is a start. We've already had people come in and make very valid points around it's not addressing the whole spectrum of palliative care, and we need to think about other models and adjusting over time. I think those are valid points, and we listen to that, and we do want to learn from that and adjust as we go.
Can I just follow up? So thank you, Patrick, for those comments. Now, given the two things, the data that exists in terms of utilization of hospice, which is pretty pitiful, and the interesting data that Hal just shared with us in terms of how they've modified the entry point for hospice, extended it beyond the 6 months, co-treatment, much more consonant with what exists in palliative care as compared to traditional hospice care. How does that get you thinking about changes in the CMS policy?
Yeah, so as I'm sure you know, let's do, I always try to separate sort of statutory and regulatory. Right. So, on the statutory construct, there's a statutory construct for hospice, which you all know very well, that, Congress could choose to modify, and there's been various bills, et cetera, looking at that issue. As a member of the executive branch, I can never ask anyone to lobby Congress, but right. Certainly there's some statutory constraints, if you will.
But you could take executive action.
So the other method...
You didn't respond to that.
So the other, let me explain what we can do just to walk out care choices a bit, if it were successful, as an example, if that's okay. So, we, as I said, are working to launch the model soon. If successful, which in this Innovation Center statute means, improves quality and lowers cost, which I think, we're launching this model because we think it can be successful, and we heard some evidence that points to its likelihood of being successful. We then do have the regulatory authority, the executive action authority, or the regulatory authority to say, we are now going to expand up to nationally and up to without an end date a given Innovation Center program. So, what I think is a positive of the Innovation Center statute is it enables the agency to test models of care and expand them, which is very different than our traditional demonstration authority, which was, long demonstration, report several years later, hoping that someone can expand or scale. So I think there's a real opportunity there.
Great. Can I just follow up one more step, Judy? Is that okay? So, we talked this morning about the need for some urgency in moving things forward, and I think we all recognize the future, which is that there's going to be a large number, an increasing number of members of Medicare. So policy change takes a long time, but there are some things that might be doable. We've just talked about one of them, which might be modifying and extending the length of time using co-treatment. I'm going to ask Hal in a moment if he could speak about how Aetna is trying to generalize that to other private partners and payers. But what about the rather dramatic history that existed as part of the ACA in 2010, January, when the whole issue of payment for conversations was first on the table coming and then suddenly withdrawn.
Is that for me, or?
That's for you.
I'm afraid it's for you, Pat.
Yes, so I'm so glad I'm here today.
I'm glad you're here as well.
What I would say, and I'll speak to this as a clinician and a family member, if that's okay. So, I think we want to align incentives so those conversations can occur between a clinician and a family. And so, and some of those incentives are financial. There's other incentives as well. Sure. And I think, our broad policy goals is to align incentives in a way that it empowers those conversations to occur, and that beneficiaries, their families, and caregivers can express care choices. And we have the incentives for providers both to ask those questions and then to execute on those care choices, and really have a care management team around the beneficiary. I mean, the fee-for-service environment traditionally has not incentivized that type of care coordination. We're really trying to shift to more of an outcomes-oriented, patient-centered care team environment around patients and families.
Yeah, but one of the commodities that's so important is just having time. And it's so hard to have those discussions in a very short time, which is why allocating time for that is such a critical component. Do you agree?
Yes. And feel free, I'll talk and then you can jump in.
He would like you to bail him out here.
No, but I'll use an example. One of our comprehensive primary care practices in Arkansas, originally for physician practice, now has expanded to nurse practitioners, care coordinators. They have various colored teams.
Sure.
Great practice where this is the discussion they have. The internist in that practice, I spoke to him. He said, I finally get to practice medicine the way I want to.
Yeah.
We do visits into the nursing home. We do home visits. We do, we are communicating electronically with the beneficiaries that's their preferred mode of communication. I mean, it is a different care model. And I think there, we and other private payers partner together and put in, population-based payments to allow that practice. Sorry, one more quote. He was like, this was $1 million of total fees that went into this practice. They lowered total cost of care significantly more. And his point was, I'm a small business. I would have had to mortgage my home 5 times over to make this transition. And you've now helped me as a group of private payers in the state, in this case, it's in Arkansas, make that transition. I think that's the kind of environment we want to create that allows clinicians to practice medicine and interact with patients and families the way we want.
In that regard, very good. Yeah. That was good. I was going to say how maybe you could talk to us a little bit in terms of the Medicare Advantage piece that you have, what kinds of conversations that you're tracking and that that people are having.
Yeah, and I would just take a step back, and your point was well taken, 50 years, and look how much healthcare delivery has changed in 50 years. I mean, I remember it wasn't much longer than 50 years ago that we had a GP caring for us. He was a solo practitioner working out of a little office, and he would take 1 week off during the summer and have someone else cover for him, and that was our health care. He'd come to the house with literally a black bag, and he would get paid in cash. Now, not everyone remembers that, but some of us do. And we're still paying on a framework that was in place roughly 50 years ago, but the place I left 8 months ago was an integrated delivery system which had 65 clinics across central Pennsylvania. It was investing huge amounts of money in post-acute care for all the reasons we're talking about. Right. And one of the things I'm really proud of at Aetna is we now have over 100 ACO relationships where we're incrementally moving towards value payments so that these activities can be rewarded within the systems. And really trying to solve this problem, this challenge that we have in figuring out how to account for all this using the existing structure we have for reimbursement is enormously challenging. And I think this move towards population health, this move towards value payments really allows us to begin to do this in a comprehensive way. I frankly can't think of any other solution because I think the complexity of the existing system, for all the reasons that Patrick described, makes that really encumbered.
We've talked a lot about the difference between delivery systems and financing and payment and reimbursement. And which one is the tail wagging the dog kind of thing. But this is the part where we're talking about the delivery of the services. How would you envision from both of the programs that you've been talking about, some of the innovations, Patrick, certainly what Aetna's been doing, we've all been pointing to, what elements do you need to have to be different to really serve this population in a way that the report envisions?
So I think it really depends on a team-based approach. This shouldn't be a physician, I say this as a physician, it can't be a physician-centric model. What physicians play a critical role as part of the healthcare team in addressing these end-of-life issues for a whole set of very important reasons. But at Aetna, the individuals that are really driving this process are nurse case managers. They're a critical part of the team as well. And again, if you go back 50 years ago and look at the structure we have for addressing reimbursement, it makes it difficult to really enforce this notion of an integrated team structure. And one of the things that we do at Aetna is we have what we call enablement tools. They could be IT-type technologies, they could be our nurse case managers, they could be various mechanisms to work with provider partners to enable them to move towards population health, to take risk, and to care for a population. Because I think all of us, as patients and as members of this large community, want to see us move in that direction where the measures are really about outcomes at the end of the day. Can we demonstrate value in terms of how we deliver care, appropriate care at the right time, at the right place? And as someone that was CEO of a hospital not that long ago, I'm pleased to say not always should that be in a hospital.
That's right.
In that regard, actually, and then, this is an issue we haven't really talked about much today, and yet it's very much prominent in the report, is the role of electronic health records and technology in allowing a person's wishes and what they care about to follow them throughout the system. Where are you all on looking at what the future will bring with that?
So one of the things we haven't talked a lot about today is the role of the non-professional caregiver in end-of-life care and in hospice. And they're a crucial part of the equation. It's the immediate family member or friend that's integrally involved in the care of a patient who's at end of life. And I think one of the compelling questions we have is what are the systems, the information systems we have that can incorporate them into that care process? And unfortunately today, there are very few, and we all know the challenges of interoperability, but also the lack of technologies that allow us to do that. And I think and I've seen a couple of systems that may offer some opportunities here to that challenge, but we need to find ways to better incorporate not only the patient, but their family and friends into the process to really provide a comprehensive set of solutions to addressing end-of-life care.
Just to make one quick comment on that, I agree with you about the interoperability, and I agree with you about the need for these services, but I'm sure all of us have found it remarkable that if you go to your local drugstore to renew a prescription in advance, that they actually know when it was prescribed, and they've got all the information in hand. So, there are systems available that can be deployed for these reasons. They've just not been. Why?
I'd like to think the reason is we're still in the very early, shallow phase of this IT curve, and that the solutions are coming fast and furious. It wasn't only a few years ago, I remember that there were engines that you could purchase to try to get one system to talk to another, interface engines. And now you look at what various vendors are coming up with to create that interoperability. It is impressive, but without a doubt, it would just be a lot simpler if these things could talk to each other right out of the box. But
a couple brief thoughts. We're going to release the meaningful use stage 3 rule very soon. We've said that publicly. And we think interoperability is one of the key functions. And, right. I think the ideal that we would want, all of us in the health system, would be that a patient's care choices are proactively identified in a record and travel with them, so that those are known at different points of care. And so I think, a lot of work to get there around standards and interoperability, et cetera, and don't want to minimize that complexity, but I think, we are driving to a patient-centered record that moves with said patient or person.
So recognizing that you can't speak to a rule that's not out yet.
Yes.
We do know that in the old meaningful use that there was a checkbox for advanced directives, and there's some hope that maybe at least a PDF could be put in place instead of just a checkbox, but that would be something some of us are looking for. What other kinds of things could we hope for?
Yeah, so I think, this is feel free to add on. I think it's a evolution. I think, ultimately we'd want more than a checkbox, and we could discuss, what the standard of transmission would be if you want. But I think we would want the ability for a patient to enter information or a clinician to collect that information, hopefully in a standardized format with some standard data elements that then travel with the patient. We haven't talked, I'll pivot a little bit if that's okay. We haven't talked about the Impact Act today. I don't know if you did earlier, but I think, you know, a congressional statute that squarely lined up in post-acute care, you know, core aspects and data elements that would track across post-acute care settings. So I think that's the kind of framework that we want to move to.
Yeah. You know, one thing that along these pathways, Hal, to you, it's interesting that some years ago when the ACA was coming into play, a lot of the jargon, aside from death panels, was about insurance reform and the need for it. And there was a lot of need for it, and I think you would agree that that's the case. And yet, here we have a private company, public company like Aetna, taking major innovations in this area, which is really quite striking. So it seems to me that there are two things at hand. One is, how do you generalize from what Aetna is doing to other public companies to, you know, span the scope? And the second is, there must be a kind of behind-the-scenes analysis that Aetna has done. I'd like to think that you always you're putting the patient first, and this is a public service, but there's an economic, financial, you know, incentive behind this. There must be cost savings that you're envisioning, which are part of these things which are important to do. If you can enhance quality and outcomes and satisfaction and quality of life and death for people and make it more cost effective, that's a great thing. So what's been the thinking behind
Well, you know, I think it frankly starts with the culture, and probably many of you saw the articles in the paper a few weeks ago that Aetna was probably the first Fortune 100 company to increase the minimum wage to $16 an hour. That cost us more money up front, but when you start to calculate the return on that investment in retaining employees and paying a fair wage, and also it wasn't just the minimum wage, it was also these employees' health benefits as well. The dividends are huge. It's about doing the right thing. We believe, and again, within the constraints of the existing regs that we have for our Medicare enrollees, doing the right thing for our members is what we're about. We're a health company. We may not be directly in the healthcare business, but we're a health company. And first and foremost, we think it's ethical and right to do what's correct for our members. Number two, if you do that, it will economically make sense.
Yeah.
And I think I gave you that example of a savings of roughly $13,000 per
that's
individual.
a great example.
It did make sense, but that's not what drove the equation.
Yeah, no, I appreciate that.
It's about the quality, and that quality does drive a value proposition.
So what about generalization to other companies? Are they looking at you and saying, gee, Aetna's got it right?
Right.
We'd like to join in?
I was going to tag team with Phil. You know, how come everybody's not getting what you have?
You know, I'm probably not the right person to ask that question.
Any other insurance executives here? Should we go to the audience?
Go to the audience.
All right.